maybe a couple of weeks into your emergency room rotation, right? And suddenly, the double doors fly open.
Oh, the classic ER entrance.
Exactly. A panicked owner rushes in, and they're carrying a male cat wrapped tightly in a towel. And they are just frantic.
Right.
They tell you, like, he's been running to the litter box all day, straining, crying, but, nothing is coming out. And then they say, now he won't even lift his head.
Which is terrifying for an owner.
Totally. So you look at the cat, and he's profoundly lethargic, cold to the touch. His breathing is really shallow. You are basically looking at the classic high-stakes presentation of a blocked cat.
Yeah, and it's one of the most critical scenarios in veterinary medicine because it is an absolute masterclass in dissection.
How so?
Well, to the untrained eye or even, a panicked owner, it looks like a localized mechanical issue, like a simple plumbing problem.
Like a blockage.
Exactly. But beneath the surface, that physical blockage has triggered this systemic, rapidly fatal metabolic collapse.
Wow. Okay, so today we are doing a deep dive into a comprehensive clinical guide on urinary tract obstructions, or UTOs. And we're going to extract the exact pathophysiology and the emergency protocols you need to handle this.
Right, because the mission here is really to bridge that gap between the textbook theory you've been reading and the chaotic, fast-paced reality of the clinic floor.
Exactly. We need to arm you with the knowledge to recognize the trap before it springs. So before we even look at the emergency crash cart, we kind of have to understand the physical mechanics, right?
Yeah, we have to start with the plumbing.
Right. So the definition of a UTO is fairly straightforward. It's just a restricted flow of urine, anywhere from the kidneys all the way down to the external urethral orifice. But right away, we need to talk about the pathophysiology of pressure.
Because the full bladder itself, that's not actually the direct threat to the animal's life.
Wait, really?
No, I mean, the threat is what that full bladder does back up to the kidneys.
Yeah.
You have to remember, the kidneys are essentially these highly sophisticated, pressure-driven filtration plants.
Right.
In the microscopic nephrons, specifically at Bowman's capsule, blood is filtered based on a very delicate hydrostatic pressure gradient.
Okay.
So the pressure pushing fluid out of the blood vessels and into the tubules, it has to be higher than the pressure pushing back.
Makes sense.
But when a physical or functional obstruction happens in the urethra, urine just keeps accumulating. Luminal pressure builds inside the bladder and, well, because fluids are non-compressible.
Right, that pressure has nowhere to go but backward.
Exactly. It transmits directly back up the ureters and right into the kidneys.
I always kind of think of it like capping a high-pressure water main. The water doesn't just stop at the cap. The pressure wave travels all the way back to the pumping station.
That's a great way to put it.
And once that backward hydrostatic pressure inside the renal tubules equals the forward blood pressure driving the filtration, the glomerular filtration rate, or GFR, it simply ceases, right?
It's total standstill.
The kidneys just completely shut down. And the moment that filtration gradient hits zero, the clock starts ticking on the patient's life.
It really does. And the clinical guide points out that this scenario predominantly strikes males. So male dogs and male cats.
Because of the anatomy.
Yeah, exactly. The male anatomy features a much longer, narrower urethra, so it's just a natural bottleneck. In male dogs, the culprit is most frequently intraluminal.
Meaning, like, a physical object inside the pipe itself.
Right, like uroliths or stones, usually lodging right at the base of the os penis. But in male cats, you're usually dealing with urethral plugs.
Which are gross.
Yeah, they are. They're this gritty, almost toothpaste-like mixture of proteinaceous matrix and microscopic crystals.
Okay, but the blockage isn't always a physical plug of debris, right?
Yeah.
The clinical materials outline intramural causes as well.
Yes, issues originating within the wall of the urinary tract itself.
Right, so neoplasia, particularly tumors at the bladder neck or along the urethra, I know that's a major factor in older dogs. And then prostatic enlargement or cysts can physically compress the urethra from the outside.
Right, exactly. But then there are the invisible functional obstructions, which are wild.
Oh, yeah.
You can have severe edema, hemorrhage, or just aggressive spasms of the urethral sphincter muscles.
So no stones, no crystal.
None. You can have a patient with absolutely no crystals, no tumors, nothing, but the urethra has spasms so violently that it creates an impenetrable wall.
That is crazy, and I guess that's why the diagnostic phase is so fraught with pitfalls.
Oh, it is. The clinical presentation routinely misdirects the owner.
Because they see their dog or cat, frequently posturing, straining aggressively, crying in the litter box or the yard, and the immediate assumption, almost universally, is constipation.
Yeah, they assume the animal is just trying to pass stool and can't.
because the straining looks entirely identical to an untrained observer. But for a student in the clinic, I feel like a more difficult diagnostic hurdle is differentiating a blocked cat from a cat suffering from feline idiopathic cystitis, FIC.
Absolutely. That is a huge trap.
Right, because both present with an agitated cat making 20 trips to the litter box, licking their genitals, showing severe pelvic discomfort. In the waiting room, they look exactly the same.
Exactly the same.
But the moment you put your hands on the animal's abdomen, the difference is night and day.
It is. Palpation is your definitive initial tool here. When you palpate the caudal abdomen of a blocked patient, you're going to encounter a large, turgid, rock-hard bladder.
Like a water balloon on the verge of bursting.
Yes, exactly. But if the cat merely has cystitis, the bladder is usually small, maybe the size of a walnut.
Because the severe inflammation is making them void constantly, the bladder never even has a chance to fill.
Exactly.
But, okay, let's consider the patient who isn't closely observed. Like an indoor-outdoor cat or a dog whose owner works, 14-hour shifts. The owner completely misses that straining phase.
Right.
So by the time they finally bring the animal in, the presentation has fundamentally shifted.
It has. If the obstruction is complete and it's been ongoing for, say, 24 to 48 hours, the urinary signs actually disappear.
Wow.
The bladder has stretched to its absolute maximum, the GFR has stopped entirely, and the patient presents purely for signs of advanced uremia.
So they're vomiting, severely anorexic, profoundly lethargic.
And often hypothermic, yeah.
Hmm.
Their mental status is altered. They might appear stuporous or just not responsive. The owner brings them in thinking they ate something toxic or have a bad GI bug.
Which brings us to the actual mechanism of death in these patients, because the plumbing problem is really just the catalyst. Once GFR drops to 0, a highly toxic metabolic brew accumulates in the bloodstream.
Yeah, the clinical guide identifies a lethal triad that results from complete obstruction. It's uremia, acidemia, and hyperkalemia.
Okay, let's break those down. So the toxins the kidneys normally excrete, like urea and creatinine, they build up and cause severe nausea and ulceration. That's the uremia.
Right.
Then the kidneys also stop excreting hydrogen ions, which drops the blood pH and causes severe metabolic acidosis, the acidemia.
Yes.
But the immediate life-ending threat is the hyperkalemia.
Absolutely.
Right.
Because potassium is heavily regulated by the kidneys. When they shut down, potassium levels just skyrocket. And the reason this is so terrifying is that potassium dictates the resting membrane potential of cardiac muscle cells.
The heart.
Yes, the heart. Normally, you have high potassium inside the cell and high sodium outside, which creates an electrical charge across the cell membrane. But as extracellular potassium rises, that concentration gradient shrinks.
So the resting membrane potential becomes less negative, moving closer to the threshold.
Exactly.
Which means the heart muscle cells become dangerously excitable at first. But as the potassium keeps climbing, the cells eventually become unable to repolarize at all, right? The electrical system of the heart essentially shorts out.
It does. And you can actually track this progressive electrical failure on an ECG. It follows a very predictable, frankly terrifying sequence.
What does it look like?
Well, initially, as repolarization speeds up, you see tall, tinted T waves. Like the T wave can become even taller than the R wave.
Oh.
Yeah. And then as the toxicity worsens, the resting membrane potential drops so much that the conduction velocity slows down, the PR interval prolongs, the QRS complex widens out significantly.
And eventually, the atrial muscle completely loses its excitability. The P waves disappear entirely.
Exactly. You're left with a wide, bizarre QRS complex and a dangerously slow heart rate. It's called atrial standstill.
I remember being on the floor early in my training and seeing a blocked cat whose heart rate had dropped to like 80 beats per minute.
Oh, no.
Yeah. My first thought was, oh, fantastic. The buprenorphine we gave him is finally working. He was screaming in pain 10 minutes ago, and now he's relaxing.
Oh, man.
But my resident took one look at the monitor and just panicked. It took me a minute to realize the clinical trap I'd just fallen into.
It is one of the most dangerous assumptions you can make. I mean, in a highly stressed, intensely painful, severely dehydrated animal, physiological rules dictate they should have sinus tachycardia, a very fast heart rate.
Right.
If a blocked, painful patient is bradycardic, they are not relaxing. Their cardiac conduction system is failing. That slow heart rate is an immediate trigger to get ECG leads on them and pull a venous blood gas or electrolyte panel right away.
Because it's impending cardiovascular collapse, plain and simple.
Plain and simple, yeah.
And while you're pulling that blood, The source material notes several other lab abnormalities
That's
they'll
fine.
encounter, right? Like you'll see a stress leukogram on the CBC.
Yeah.
On the biochemistry panel, alongside the hyperkalemia and azotemia, you'll see hyperphosphatemia because the kidneys can't excrete phosphorus. You'll also frequently see decreased ionized calcium, which further destabilizes the heart.
Right.
And in cats, the massive stress response often causes severe hyperglycemia. But if you have a bradycardic blocked patient with no key waves on the ECG, your diagnostics and your treatments are no longer sequential.
No, they have to happen simultaneously.
You are looking at a metabolic time bomb.
You really are. The emergency management protocols require you to execute dual simultaneous goals. You have to combat the life-threatening metabolic derangements, so protecting the heart from the hyperkalemia, while simultaneously establishing urinary patency to resume GFR.
You're basically playing the role of a biochemist and a plumber at the exact same time.
Yes.
So let's tackle the biochemistry first. We pull the blood, the potassium comes back at 8.5 millimoles per liter, and the ECG looks like a sine wave.
Very bad.
Very bad. The very first drug the protocol calls for is calcium gluconate. The dose is 1 milliliter per kilogram, given slowly intravenously over 3 to 5 minutes.
Right, but the administration of calcium gluconate requires continuous ECG monitoring. You have to titrate the dose based on the resolution of the ECG abnormalities. The moment those wide QRS complexes start to narrow and the heart rate improves, you stop the infusion.
I've always thought of calcium gluconate as a bulletproof vest for the heart. It's vital to grasp that injecting calcium does absolutely nothing to lower the potassium levels in the blood.
Nothing at all.
The hyperkalemia is the active shooter in this scenario, still roaming the hallways. The calcium simply restores the difference between the resting membrane potential and the threshold potential. It puts a vest on the cardiac muscle cells so they don't get taken down while you work on actually disarming the threat.
That's a perfect analogy. And to disarm the threat and physically move that potassium out of the bloodstream, you rely on regular insulin.
Okay.
The protocol dictates 0.1 to 0.2 units per kilogram given IV. Insulin stimulates the sodium-potassium AT-PACE pump on the cell membranes, actively driving potassium from the extracellular fluid back into the intracellular space.
Well, wait, insulin is indiscriminately going to drive glucose into the cells as well, which will completely crash the patient's blood sugar.
Right, which is why you have to follow the insulin immediately with a dextrose bolus.
Okay.
So 1 milliliter per kilogram of diluted dextrose IV over 5 minutes. And then you place them on a 2 to 5% dextrose continuous rate infusion for the next 4 to 6 hours to prevent severe hypoglycemia while the insulin does its work.
Got it. And what about in really extreme cases?
Well, if the potassium is over 10 millimoles per liter and you have severe acidemia with a blood pH under 7.1, the clinical guidelines recommend sodium bicarbonate.
Given at 1 milliliter per kilogram IV over 5 to 10 minutes, right?
Yes. The bicarbonate actively buffers the acidemia, and as hydrogen ions move out of the cells to buffer the blood, potassium moves into the cells to maintain electrode neutrality.
Okay, so the heart has its bulletproof vest. The potassium is being forced back inside the cells. The ECG is starting to look like a normal rhythm. We've bought ourselves a crucial window of time.
We have.
Now, we have to fix the plumbing. We have to relieve that intense hydrostatic back pressure destroying the kidneys. And the guide discusses performing a decompressive cystocentesis prior to attempting catheterization.
It does, yeah.
When I first read this, it sounded insane to me.
It sounds counterintuitive.
Right, because poking a needle into a maximally distended, paper-thin, severely inflamed bladder seems like a guaranteed way to pop it and flood the abdomen with toxic urine.
The fear of iatrogenic bladder rupture, or uroabdomen, is entirely valid. It is a procedure that carries inherent risk, definitely. But you must weigh that risk against the physiological reality of the patient. If you attempt to pass a catheter against a bladder that is pressurized like a drum, the resistance is immense. You are far more likely to cause severe urethral trauma, tearing, or strictures.
Oh, I see.
So by performing a decompressive cystocentesis, you instantly relieve that intravesicular pressure. The hydrostatic back pressure on the kidneys drops, buying the nephrons a chance to survive.
But there is a very specific technique to mitigate that risk of rupture, right? You don't just jab a needle in and attach a syringe.
No. Safety requires using a 22-gauge needle attached to an extension set and a 3-way stopcock operated by an assistant.
Okay.
This ensures the needle remains perfectly still while the assistant draws the urine. And more importantly, You never empty the bladder completely.
Because if you drain it entirely,
The inflamed, thickened walls will contract violently around the sharp bevel of the needle, slicing the tissue and causing a massive leak. You only remove enough urine to relieve the critical tension.
wow, okay. So once that pressure is reduced, you move immediately to urethral catheterization. And the guidelines are absolutely adamant about this. This must be performed under heavy sedation or preferably general anesthesia, depending on cardiovascular stability.
Right? You cannot pass a catheter in an awake, thrashing animal with an inflamed urethra.
It's just not going to happen.
Exactly. In dogs, navigating the catheter past the os penis, where stones frequently lodge, it requires profound muscle relaxation. And once the catheter is successfully advanced into the bladder, the flushing begins.
The messy part.
Very messy. You are dealing with highly irritating grit, blood clots, and crystalline matrix. You must instill sterile saline and pull it back out repeatedly until the effluent is crystal clear.
Because leaving even a small amount of debris guarantees the new catheter will obstruct within hours. Okay, so the blockage is out. The urine is flowing through a sterile collection system. The ECG is stable. You might feel the urge to take a breath and relax, but don't.
All right, don't.
Welcome to the recovery minefield. The next 24 to 48 hours require intense microscopic nursing care because the patient's body doesn't just return to baseline, it severely overcorrects.
It does. The immediate postoperative period is characterized by post-obstructive diuresis.
What does that mean practically?
Well, while the kidneys were shut down, massive amounts of urea accumulated in the blood. As GFR resumes, that urea is filtered into the tubules. And urea acts as a potent osmotic diuretic. It physically pulls water with it.
Right.
Additionally, the renal tubules have temporarily lost their ability to respond to antidiuretic hormone due to the pressure damage.
So the kidneys basically go rogue. They start dumping massive volumes of urine. You cannot simply put this patient on a standard maintenance rate of IV fluids, right?
You absolutely cannot.
You are rigorously quantifying their urine output every few hours and matching their fluid intake to their ongoing losses. If they are urinating 50 milliliters an hour, you must administer at least 50 milliliters an hour of IV fluids, or they will rapidly become hypovolemic and crash again.
Exactly. And there is a treacherous metabolic swing here. We spent the entire admission phase fighting hyperkalemia, dangerously high potassium.
Right, trying to push it into the cells.
But during this massive diuresis, the mechanism reverses.
Because the massive flow of urine aggressively washes potassium out of the body.
Yes. Within 12 hours, a patient can swing from life-threatening hyperkalemia to profound hypokalemia, dangerously low potassium,
Wow.
which causes severe muscle weakness, ileus, and respiratory depression. You must monitor their electrolytes frequently and supplement their IV fluids with potassium chloride the moment the levels begin to drop.
Okay, and we also have to manage their pain and sedation carefully, and the pharmacology here is full of logical traps.
No, it really is.
The clinical guide strictly separates sedation protocols based on patient stability. If the patient is completely stable, has normal kidney values and normal blood pressure, a combination of acepromazine and a pure mu opioid, like methadone, is highly effective.
Right. But if the patient is unstable, still dehydrated, or metabolically fragile, acepromazine is strictly prohibited.
Right.
You rely on an opioid paired with a benzodiazepine, like midazolam.
Why is acepromazine prohibited?
Because acepromazine is an alpha-1 adrenergic antagonist. It causes profound peripheral vasodilation, which significantly drops blood pressure.
Oh, I see.
So in a patient whose kidneys have just suffered a hypoxic pressure injury, dropping their perfusion pressure further will push them over the edge into acute irreversible renal failure.
Okay, makes perfect sense. The guide also calls out ketamine, explicitly stating it should be avoided in unstable patients until dehydration and hyperkalemia are fully resolved.
Right, because ketamine stimulates the sympathetic nervous system and can induce cardiac dysrhythmias.
Which is a massive liability for a heart that is just recovering from a hyperkalemic electrical crisis.
Exactly.
Now, here is another massive trap for students. You've just unblocked a cat. You know the bladder wall is incredibly inflamed, the urethra has been stretched, traumatized by the plug, and irritated by the catheter.
Yes.
Every instinct screams at you to reach for a non-steroidal anti-inflammatory drug, an NSAID like meloxicam, to aggressively shut down that severe inflammation. Why is that a terrible idea?
Because of how NSAIDs function at the renal level. NSAIDs work by inhibiting the production of prostaglandins. Under normal conditions, that's fine. But in a compromised kidney, Prostaglandins act as vital vasodilators for the afferent arteriole, the vessel delivering blood into the glomerulus.
Okay.
They keep the blood flowing when the kidney is under stress. So if you block those prostaglandins with an NSAID in a patient recovering from a massive pressure injury, the afferent arteriole constricts.
You essentially starve the kidney of oxygen and blood flow, guaranteeing acute kidney injury.
Exactly. It's the exact same logic with corticosteroids.
Yeah.
The protocol strictly forbids using steroids while a urinary catheter is indwelling.
Because a urinary catheter is a direct, artificial highway for bacteria from the outside world into the bladder.
Right. And corticosteroids profoundly suppress the local immune response. If you combine an open physical pathway for bacteria with a suppressed immune system, you are guaranteeing a massive hospital-acquired urinary tract infection.
Which perfectly aligns with the guide's firm stance on antibiotics. You never, ever administer prophylactic antibiotics simply because a catheter is in place.
Never.
You only initiate antibiotic therapy if an active infection is strongly suspected based on urinalysis or confirmed via cytology and culture. Firing broad-spectrum antibiotics at a catheterized patient just in case doesn't prevent infection. It just selectively breeds highly resistant superbugs that will be nearly impossible to clear later.
Exactly. Postoperative management is a masterclass in balance. You are monitoring fluid output, tracking the volatile electrolyte swings, and managing their pain. And for feline patients, the protocols strongly recommend urethral relaxants, such as prazosin, an alpha-1 antagonist, to treat neurogenic urine retention.
Because the urethra has been so traumatized that it will reflexively spasm shut even though the physical plug is gone.
Yeah, and prazosin helps break that spasm.
So you keep them on pain medications and urethral relaxants for 5 to 7 days post-discharge. You have a long conversation with the owner about increasing water intake, switching to wet food, adding water fountains, and implementing heavy environmental enrichment to drop their stress levels because the risk of reblocking within the first week is incredibly high.
It is very high.
So what does this all mean for you on the clinic floor? Treating a urinary tract obstruction requires a constant, rapid shifting of perspective. You have to zoom in closely on the physical urethra, the mechanical plumbing, the grit, the catheter, and then you have to rapidly zoom out to evaluate the systemic metabolic profile, the cell membrane potentials, the GFR, the electrolyte shifts. You are managing the micro and the macro simultaneously. If you focus only on the plug, the heart will stop. If you focus only on the chemistry, the kidneys will rupture.
It demands total clinical awareness. You relieve the physical obstruction, but the survival of the patient depends entirely on how deftly you manage the systemic fallout.
I want to leave you with a final thought to mull over as you prep for your next shift. We discussed how, especially in cats, these obstructions can be entirely idiopathic. No crystalline matrix, no stones, just severe localized edema and functional spasms acting like a concrete wall.
Right, the functional obstructions.
It forces a fundamental question. If a life-threatening, purely functional obstruction can occur without any physical debris, how much of this critical emergency is actually being driven by the central nervous system?
That's a fascinating way to look at it.
If severe environmental stress can trigger a sympathetic nervous system cascade so violent that it completely clamps the urethra shut and shuts down the kidneys, it changes how we view the disease. It challenges you to look past the physical anatomy of the bladder and consider the entire neurological state and environment of the animal. Sometimes the most dangerous blockages you will face aren't made of stones or crystals. They're manifestations of pure stress.
It really highlights why the environmental management post-discharge is so crucial.
Absolutely. So the next time those ER doors fly open and a panicked donor hands you a lethargic cat that hasn't peed in 2 days, remember the physiological trap waiting for you. Trust your abdominal palpation, respect the lethal chemistry hiding in the blood, and always, always check that heart rate.